Well, guys, welcome back. I'm so excited to have another guest on our podcast. This is Amy Harlow. But first, I'm Dr. Callie Hale.
And I'm Dr. Kyle Hale.
And Amy, why don't you tell us about yourself? Welcome to the Sleep Well Journey podcast.
Thank you. Okay, so I am a mental health therapist. So my full title is I'm a licensed professional counselor associate supervised by Dr. Cynthia Coronado. I have to say the entire thing because when you are not independently licensed, you have to say your supervisor's name.
Sure.
So I was in education for 8 years. I taught kindergarten and first grade. And then I went in to be a school counselor, and I was a school counselor for the last 5 years. And then I decided that I was going to leave that and do private practice full time.
Yay, good for
So
you.
here we are.
Yeah,
That's
awesome.
wonderful. What helped spark that transition for you?
So I wanted to stay at the school for like another year. I loved the campus I was at. My kids went there with me. We don't live in CCISD zone, but they went with me. And so I liked that they were there with me. But I was coming home every night at like 6:30. I would start my clients. So like my husband would get home at 6, take over, and I would start clients at 6:30.
Wow.
And him and I had this conversation like, I don't think this is doable for our family. Like,
Right.
we don't want to do this. So he said, how about have you considered just leaving and then doing this full time? And I said, well, I have, but I didn't want to ask.
Oh,
Because-
venturing into the unknown.
Yeah, because
Yeah.
I mean, that's not a guaranteed, I can't like the days look different, the weeks look different, how many clients want to
Sure.
schedule. And so, with school counseling, you're there, like
Right.
you have your job and it's, your job's not going anywhere.
Absolutely.
Like they need you. And
Yeah.
so,
It's a small business. There's risks and fears with all of that.
yes,
Absolutely.
But when he said that, I thought, okay, he goes, I believe in you. You can do this.
Oh,
And I was like, all
that's
right,
so
well,
sweet.
Good job.
well, let's
Good
try
job,
it.
husband.
And so, it's been going really well. We actually just bought a 14 by 30 like shop
Oh,
on the
nice.
back half of we live on 2 acres. So the back half of our property is where the shop is, and he's going to build it out, and that will eventually be my therapy office. Right now, I just see the clients in my home.
Okay, wonderful. And how many years have you been doing it privately now?
Well, it just since April.
Oh, that's amazing. Oh my gosh. Are you staying busy enough to you can kind of dictate your
I am staying
schedule
busy
and-
enough. And going into it, I was like, I'm going to take Fridays are going to be like my off days. Like, I'm not going to have clients on Fridays. Well, of course, people were like, Fridays are really good for us. And I thought, okay, well, you know what? There's no off day.
Yeah.
It just depends on the
Oh,
week,
sure,
who I
of
have.
course.
But it's been, and I see mostly kids.
Okay.
So
Wonderful.
I see kids 4 and up,
Okay.
adolescents, couples, families, adults, but most of my population are kids,
Okay.
which is what I know
Yeah.
the best.
I
So.
love that. That's wonderful. What made you want to do this?
Well, my bachelor's degree is in psychology.
Okay.
And I wanted to do this back then, but I didn't want to go back to school yet. I just was kind of finished up. And so I took a really long path to get here.
It's okay.
I graduated. I was a gymnastics coach for a long time. I was a hospice caregiver. And then I decided to do the alternative certification. And I got that teaching certification, but I didn't use it for like a couple years. So I worked in the engineering world.
Wow. Oh my gosh. You've been all
Everywhere.
over the block. Wow.
I've been everywhere. That's where I ultimately met my husband. I was in procurement and he's an engineer. So, and then I finally went into teaching and I was like, I like this, but I don't know if I like it enough. So should I go get a master's degree? And then I did. And now I'm trying to talk Ryan into letting me go get a PhD.
Oh, that's amazing. I don't think he's going to tell you no. I just don't.
He has told me no.
Oh, okay.
Oh,
He's
come on,
like,
Ryan.
he was like, will it benefit you? And I was
Right.
like, my brain, it will. Like,
Yeah.
financially, no.
Yeah.
I don't
It's
need
going to
it.
cost money, tears, time. Yeah.
But
So you asked him for a PhD and he bought you a shop?
yeah. He was like, no PhD, but here's a shop.
I think that's good too.
Yeah, it's a fair
Just give
trade.
and take.
And I don't really need one, but like, I want one.
Yeah. Oh, that's amazing. So, when Bree reached out to you and we had that big dinner and the first time we met, given all of your knowledge in behavior, in counseling, in these children, was sleep in your path of education and kind of what I was talking about in mine, or was that fairly new?
So sleep has never been something that we've gotten in school. Like you didn't hear about it in your master's degree or even in any kind of early childhood, workshops, nothing like that.
Wow.
However, I had been and this is so, it's serendipitous in my opinion. I had been reading about it last year.
Wow.
And I had a student who was really struggling throughout the day behaviorally, and he would sleep a lot, like during the school day.
No.
And so I talked to mom and said, have you thought about a sleep study? I've been reading about ADHD symptoms and how they can, sleep disorders can mimic those symptoms. And she ended up getting a sleep study for him, and he was having 20 wake periods a night.
Oh my gosh.
And so they were able to remedy some of the things. And so whenever I heard about this dinner through Melissa, our mutual friend,
yes.
I was like, oh, that's perfect, because I've told parents sleep studies would be really beneficial, but I had nowhere to go with that.
Right.
Well, who do I talk to? I'm like, you're a pediatrician? Like,
I know. Yeah.
I don't know.
That's a really good point. The disconnect from, you need this, but where do you get it done?
Yeah. I had no resources for that. And the district that I worked in, we had a resource list for all kinds of things. We even had dentists on that list. But sleep disorder, that was never like, who do you go to for that? And there were so many kids, especially in elementary, that needed sleep studies.
Absolutely. Wow,
That's really interesting you say that, because to prepare for this, I did have to do a lot of research. And so I found one article, and I don't know if you've ever heard of a study called the Dundon study. It's in New Zealand. I think it just turned 50 years old. But it's like no other study, and they've been tracking about a little over 1,000 people that were born about 51 years ago, and they've been doing research on them. No interventions, just come in, we'll ask you questions, do surveys, and a lot of what they do is around behavior because they're kids, and they did sleep stuff, they did sleep questionnaires, and just over the years how they've changed their sleep questions that they're asking the parents, because you're asking, like, I think when they were 5 and when they were 7, they asked like 3 basic questions, just real simple stuff. And then it got to like 9 questions, but when they turned 9 years old. But when I was looking at this, I was like, I wonder if the Dundon study has ever done anything related to sleep and neuropsychological symptoms, and they have. And so it's really interesting, because now I had to do more research, because in the results it said that, and this is open source, so I don't think I'll get in trouble for reading it, but it says just in the abstract, after adjusting for gender and socioeconomic status, persistent sleep problems during childhood predicted scores on 2 neuropsychological tests. The tests were the copy score of the Ray-Osterrit complex figure test, and then 2 measures of performance from the Halstead trail making test. And it linked these problems to sleep, or these scores to sleep, and they were poor scores. So, and then I went a little bit further, and it was snoring during, found this article that was cited in the one I just read about. And it said that snoring during early childhood and academic performance, ages 13 to 14 years old, and that snoring was, let me find it here. It was 2.5 times more prevalent in low-performing children in ages 13 to 14 compared to high-performing. I haven't heard that study. And so it took the bottom quarter, called them low-performing, took the top quarter, took them high-performing. And comparing the top quarter versus the bottom quarter, you're 2.5 times more likely to have snoring if you're in low-performing. So it's making the connection. And I just think it's really interesting, because you said no one's talked to you about it. And we one of the biggest reasons that parents come back to us and tell us how awesome Callie's doing, how awesome the airway dentist in our group are doing, is because their kid's behavior is improving. The teacher wants to know what changed, right? Like, if you're a parent, are you a parent?
Yes.
So if you dreaded getting the report, how old are your kids?
7 and 5.
Okay, so not yet report card.
We get them,
but you do. You get a behavioral, like it's a part of it. Like, how are they?
E's and S's, and and so, but when you get back anything that's not an E repetitively, then you're like, what am I going to do? What am I going to change? And as a parent, I don't think there's anything better than feeling like, well, there's definitely nothing worse than feeling like you're doing something wrong, right? And if your kid's sleeping like crap, what are you going to do to fix that? Sometimes there's not a lot that you can do, and that's what our model is we need to evaluate them for, dental things that are contributing to their sleep disorder breathing and their poor sleep quality. And to not talk, it's so easy to screen for. So I want to back up. That
was one of my questions for you on here.
Oh my gosh.
I want to back up a little bit, because you talked about like all these things that you've changed, and you were in school I mean, you were not in school, but you were teaching, and then you said you had a list of, like, I guess, contacts that you could refer to or point parents in the right direction. But like, I'm really interested in, like, what kind of freedom did you have to have those conversations with parents? Or do you feel like maybe you were like, and I don't know, I'm not making an accusation to the school board or anything like that, but like, do you feel like you have the ability to have those conversations with parents to say, hey, I see these trends in other kids, and this is something that I'm seeing in yours?
So it looks a little different for teachers in the classroom versus the counselor.
Okay.
So none of us are in that role, even if you were an LPC or a diag or a diagnostician. You can't, as a teacher, say, I suspect your child has XYZ. That's a big no-no, because you're not a clinician in that setting. And so teachers have to have these like roundabout conversations with parents and have like buzzwords. Like,
okay,
I've noticed that he's having a really hard time sitting still, or that she is shouting out during, a read aloud.
Okay.
But oftentimes parents they're not picking up on that because they are, either they're not privy to mental health conditions, or, maybe it's their first kid, or they don't know anyone that has any kind of like mental health disorders or behavioral disorders. It may take like years for them to finally be like, oh, I think the teachers might have been saying that my kid has ADHD.
Right.
As a school counselor, you have a little bit more leeway to talk kind of openly about that, but you still can't say, I think you should get your kid screened for ADHD or for a behavioral disorder.
Oh, wow.
Because again, you're not a diagnostician, you're not a clinician in that setting. And so it's really hard because you want to be able to have conversations with parents that are
no
genuine.
Kidding. That's so hard.
But you can't. You kind of have to have these like, in the list that we had, the teachers didn't have access to it. It was the school counselors. Okay. And sometimes like, the admin or the SPED team leads, but it was a list of, it had doctors on it, psychiatrists, mental health professionals, resources, like if they needed help with food and stuff like that. And you would kind of like, if you were saying, I think that it might be a good idea as a school counselor, I'm psychoeducational. This is short-term, skills-based. I think that your child would benefit for a therapeutic approach. Then you could say, here's this list of resources. Maybe you could reach out to somebody on here and schedule an appointment. So it's still very
disconnected from.
Yes. It's not what you want to say.
Yeah.
And same with the principals and assistant principals. They still kind of have to dance around those kind of conversations. Absolutely. And I wish it didn't have to be that way.
I know. Oh. Is that just kind of is that a politics thing where they're afraid the parents are going to get upset and the subsequent physician's going to call the school and be mad? Like who's going to get in trouble with that? Like what?
So I think it would be that you were kind of like acting as if you were something that you weren't, like if you were a clinician. And that's not what a teacher's intent is. That is not what a school counselor's intent is. They want children to get the help they need, but parents do get offended by it. Mm-hmm. And they will go to your principal or school board and say, well, your kid said my kid's teacher said you had ADHD and they can't diagnose my kid. It's like, well, that's not what your teacher was saying. They just said, have you thought about looking into this? So it's kind of like you have to protect yourself, and it is a little political.
Yeah, yeah.
But as a mental health therapist, that's completely different because I can diagnose mental health conditions. So I can tell a parent, after working with your kid for XYZ, would you be comfortable if we did an ADHD assessment?
Yeah. Okay. Well, that leads us into the whole ADHD discussion. Mm-hmm. So in all of your training for ADHD, again, it's such a buzz in the sleep dentist community and just the sleep medicine community, because if you look back at some of the studies, I don't know if we talked about this at the Friendswood dinner or not, but we talked about Karen Bonnick and all of her research. It's Bonuck, I believe. And she followed like 11,000 kids in this very ideal setting of, okay, what is the chance of them being diagnosed with ADHD versus the kids that are sleep deprived? Mm-hmm. And it ended up being a 50-50 coin toss that the same behavior characteristics of a child displaying ADHD could actually be sleep deprived instead. Mm-hmm. And so that's where I get on my soapboxes when I'm talking to dentists and working in the community. It's like, if it seriously is a coin flip as to what the child really does suffer with, we should do a sleep study before we're putting on medications or whatever. And I never fault a parent or a family for doing that. Like, we have to help the kids, like whatever they need to succeed in that moment. But if it's something I can help them through the root cause with, I'm like, put me in, coach. Like, let's get it. Let's just save the kids. Yeah.
Well, and I was thinking about on the way over here, you think about when you're a parent of a newborn, right?
Oh, exactly. Oh my gosh.
You're so dysregulated.
100%.
All the time. And then for women, throw in some postpartum in there.
Yep.
Like, so now you're sleep deprived. You're never getting REM because as soon as you fall asleep, your baby's
waking up. Absolutely.
And then you wake up in the morning and it's so hard to just cope with everyday things. And you are an adult, so you have a better understanding of your emotions. Most people do. And you can help yourself regulate, whereas kids have no clue. And that's not on them. That's just developmentally appropriate for them. So if they're missing all this sleep.
Well, and then they're expected to go to school and sit still all day and behave like the kids that aren't tired, the kids that aren't suffering from this.
And they can't verbalize it.
And they can't, And it's sad. I mean, I'll have patients come in and for their initial assessment with me, and these kids are off the wall. I mean, they're kicking my chair, they're kicking the wall, they're like, they don't want to listen, they want to leave, they're up and down, and it is like, so a lot of the times one of my awesome staff members will grab them, take them to the kids' room and play, and I'm just with the mom, and I'm like holding her hand, and I'm like, okay, this is what we need to do. Yeah. This is what I'm seeing. We need to, this is going to be a whole team approach, but we're going to regulate, because right now, like you're saying, they're not regulated because they're not resting and they're exhausted, and the parents will just think their kid is, a brat or like just really a very difficult child. And I'm like, well, we need to make sure that we can check the sleep and the jaw development off the list. Like you need to know that part's taken care of. That's not contributing, because we see it improve once they sleep. And the other part of that is we assume sleep just means they're in their bed asleep. Like, I mean, quality sleep. I mean, I want to know that when, cause some parents will tell me, no, they sleep 12 hours. And I'm like, okay, that's not the point. We don't know what is happening in that 12 hours. And what does that quality look like? Because if they're constantly waking up, whether you realize it or not, because now they're 13 and they haven't slept with you in the same room for forever, what is actually happening? Their oxygen levels, are they snoring? I mean, it's just like a laundry list. And I'm like, the quality of that sleep is what matters, not how long it is.
Yeah. And, when you were talking about like the parents coming in and being frustrated and like, what am I doing wrong? And, and then you hear from the other aisle, well, you're just not disciplining your kid enough. And it's like, okay, so you have to look at ADHD, sleep disorders, behavioral disorders, the same way you would look at diabetes, right? Yeah. Are you going to punish your diabetic child because their blood sugar keeps dropping?
Right.
No. So you're not going to do that for your kid who has ADHD or is having, sleep issues. And of course that's different than, setting expectations and having boundaries for your child.
Of course.
That's not what you hear from other parents. When they do have a kid that has a behavioral disorder, they're like, well, they just get to do whatever they want. Or they're in the classroom and they get to go to the calm down corner. Nobody else gets to do that, and so they don't see it as the same. It's the one and the same with medical disorders.
Absolutely. Well, I mean, in the medical community, we'll look at obstructive sleep apnea, like in an adult, as a chronic condition. Without a treatment of a CPAP or some sort of oral appliance, you're going to have this for the rest of your life. And that's where I think the narrative has got to change with the kids. One, we need to recognize it. We need to recognize that all the stuff that you guys are seeing, maybe an airway dentist can help with, but that we can change that trajectory for them, because they are going to turn into the sleep apnea adult. Like, they're going to have it when they're a kid. And if nothing happens properly for their sleep hygiene, nasal breathing, jaw development, they're going to still have those problems. Why we think they would grow out of it is still, to me, astonishing. Like, it's the same person growing up with the same issues. So I think that is so key. And us wanting to collaborate with awesome people like you is, how do we connect the dots? Because if the teachers can't, like you said, have those conversations. And me, for years I've been like, I gotta talk to the teachers. Like, and then we realized, well, they want to know, they love it. They're like, hey, we're all on the same team here, but they can't like handhold them into the office. And that's where we need to have these connections, dentists all over, because we've got to be able to work together, because I don't think anybody knows this is a solution. The tooth pillows and the jaw, they don't, and where can they get that proper treatment?
Well, and parents that I've brought sleep studies up to before, they're like, well, what would that do? And it was because they just didn't have,
Right.
And most people don't. There are a lot of counselors that don't. There are a lot of obviously a lot of teachers that they don't have the information in front of them.
Right.
And they need it. And I was kind of brainstorming when you were thinking about connecting with the teachers and like how you could do that. And I wonder too, would starting with a SPED department in a district be like a good place to start?
SPED, do you mean like special education?
Yes.
Okay.
Because, not all kids that have ADHD or behavioral disorders are in the special education program. A lot of them are 504, so they just have accommodations, they're monitored, or some just aren't at all because they don't need it. But a lot of the kids with behavioral disorders do require special education programming. And to me, I'm like, would that be a good place to start with school districts on like, hey, here's some information.
Right.
And that could be, just pushed out to the team leads who kind of manage.
Yeah. The newsletter from me or something.
Yes.
Even if they can have me there. Like, absolutely. Yeah. I just know that we have to change something, because we're not a healthy society. Like our kids are suffering. There is a giant epidemic of underdeveloped jaws and tongue ties that aren't addressed and things that I know we can make a critical change so that the rest of what they're dealing with can be more easily managed. I mean, I'm certainly not saying we're going to cure every child of depression and anxiety. We're not. But if I can get their sleep quality improved so that as they're working through these behaviors and they fall asleep and it is quality, restful sleep with deep sleep and REM sleep, everybody does. We can't live without it. Right. And so I know that we can make such a profound impact. It's hard to find that niche. I am speaking at PTAC in the beginning of the year. His mom was the director of a preschool for what, 40 years?
No.
38?
Since
at a private school at Berry Christian. And she just retired like last year.
She's going to kill me for not knowing.
You're going to be in trouble for
it's
not.
been 3 decades.
30-something years. I mean, she's an expert in it. And she came and met with us and told us about PTAC. I mean, a dentist doesn't know what PTAC is. We don't have any idea. And I had to submit this proposal and they said, yes, so that'll be in January. And I'm like, good. The more information I can empower them with, because regardless if they're coming to see me or not, it doesn't matter. Because if a child gets sent to a pulmonologist or a sleep doctor, or if their pediatrician gets them a sleep study, that's another kid that is least going to be in the hands of like, oh, you have obstructive sleep apnea. Well, unfortunately, the treatment's typically tonsil nanoids or a CPAP, which that might not always be the route that it needs to go. And in fact, I think it shouldn't be. I think they should be, fed through an airway dentist first, because we can expand around the tonsils nanoids. But at least I know that there's going to be more conversations with it in the child, so should see improvement.
And it made me think again, too, talking about going to that conference, like the American School Counseling Association has a conference every year. Like that could be a good,
hook me up. Let me know.
Like
I'm there.
Well, that's why I love these. This is for me. Okay.
Yeah. You're like,
this is about me.
About you.
Well, and at the risk of sounding really dumb, something that I say to a lot of people, and I've probably said on this podcast several times already, is that if we replaced the scoliosis screening with the sleep disorder breathing screening in school, and again, like having only experienced that like 30 years ago, right? I think it's so important. And to me, it is so easy to screen for this. And then I think, if it's so easy to screen, why aren't we doing it? And probably the reason we're not doing it is because, like, what happens if you see something that throws a red flag or a yellow flag? Like, who are you going to send that child to? Now, that is probably one of the biggest political games that you could get involved with the school district. Like, okay, what for-profit place are you going to send this child? Right? And so how do you answer that question? And to me, I don't care. Like, because there's way too many kids that need help compared to the kids that are getting help. And I think that if the parents know and they start asking the question, like you said, your parents like, well, what is that going to do to get?
Those are great questions. Ask that question. Yeah.
But if we're just talking about it, like, hey, Callie in 30 minutes could tell an auditorium full of experienced teachers, what should make you ask the question? Behavior, sleepiness, right? And then what are you going to look for to make you think that this child should be sent to a dentist or a sleep dentist to be screened? Okay, another 2 or 3 signs, boom. And then you just have a place that the parent knows that they can head to. And maybe the right thing to do is to try to find a way to point them towards an organization, to find a provider through an organization, as opposed to saying, go to the airway dentist. We would love to see you, and we're going to take really good care of you, but it's more important that you get help. And one of our things, our mission statement is to rid the world of sleep disorder breathing. And and I, I would love it if Merck and all the big pharmaceutical companies had to like zoom in on our area and be like,
and wonder what's happening.
Why is Ritalin sales down? Like what's going on? Like we got to incentivize these physicians a little bit more. Like let's get more drugs out there. And that's not what we want. Right.
Because that's very political too. I'm sure,
No, not at all. I doubt it.
You're talking about politics,
that is a good point. And I've always said that too. Like, why are we screening for vision and scoliosis? I'm happy we are. Obviously, we need to do that. But this is such a bigger problem. And how can we just include a very short, like a couple of check marks and I would do it. I've offered for my own kids' private school, and I haven't been taken up on it yet. I will show up on a day, tell me what day, run everybody through it. I don't care if they come see me or not. They don't even have to know where I work. I can wear regular clothes. Like, this is not a pitch to like benefit me. Like you said, if they could go to airwayhealthsolutions.com or vivos.com and just pick a provider by them, like whatever, so that they knew that they were going to be seen by a properly trained airway dentist, then that takes the game or the politicizing and the financial aspect out of it.
Okay, I'm gonna walk out of the room, and now you can say whether my idea was bad. Okay.
I like your idea. Okay. I think it's great.
Yes.
And it could easily be done because, the nurse, she calls in, and I don't know how it looks on every campus. Every school district is different. But she calls them in like, a group of 10 of them.
Sure.
As vision and screening, and then out the door they go. And
then exactly.
You could easily have an aide in there to do the other part, to do, the screening for airway. So I think it could be done easily.
We got to do that. We got to do that.
How do we get it done?
Look,
Expand together.
Of the Santa Fe School District, are they the only school district?
That's where they are now.
And then, I have no doubt. There's no shadow of a doubt in my own mind that if this starts happening in a school, that school, 2 years later will be excelling in all academic areas because you're going to reduce the number of sleepy kids in class by half. If you can do that, that's a huge thing.
At least.
And then they'll be able to retain, long-term and short-term information. They'll be able to be more creative. They're going to pay more attention. You can teach faster. A really good airway adapted school district could just go to school Monday through Thursday. They don't need Friday.
Yeah, love it.
So
now you're really going to get
That's how you're going to get in test scores.
Yeah,
because that's all they care about.
And that's already published though, that when a kid is improved in their sleep quality, that their test, I could just drop a stack of papers on in front of them. It's like, let us,
we can help with y'all's test scores.
Exactly.
And
hey, you might have been onto something.
When you find the Dundon website, it's really cool. It's super cool. And this Dundon study, it's never going to be done again, right? Like, when are they ever going to get 1,000 people who are born in the same year or same couple of years to ever come back? And they can do it on this tiny island of New Zealand. But you can, in there, they talk about like if you score low on sleepiness, you will do better in school. If you score low on sleepiness, you will have a higher socioeconomic status. If you score low on the sleepiness, then all these other parts of life are improved compared to what is average. And so, but those are people. Those are
low meaning you don't score badly on it. Like you want a nice low, like you're not sleepy.
You're not sleepy. Yes.
Low sleep score, high academic.
Yes.
Yes. It's like golf. Sleep is like golf.
I don't know anything about
I don't
golf.
either. I'm so sorry.
I just wear the shirts.
Like that sounds cool.
Oh my gosh. Yeah, no kidding. Yeah.
All right. So what you mentioned that you started about a year ago, you started asking yourself questions about sleep. What are you looking forward to, or what do you see, or how do you see sleep in your practice now that you're in private practice since April? Your husband, Ryan, is building out your new clinic. We'll call it a clinic.
That sounds really official.
I like it.
And how do you see sleep being implemented in your own practice? Obviously very different than ours because you don't put your fingers in people's mouths.
No, I would definitely lose my license if I was doing that. Gosh. Well, I just think, so ADHD behavioral disorders are not going away, right? They're here to stay. But there are so many kids that I feel like that I wouldn't have to see long term, because the goal of therapy is not to be with me forever.
Right.
It's we want you in and out, in and out. And of course it's a process. It doesn't look like that. You're not like, of course, 2 sessions and you're like, bye.
Bye.
But the goal is for us to not be together for a long period of time. You might come back and revisit me a couple years because something else has happened that you need. But for children and behavioral disorders, we can do so much and work on the skills, but I feel like sleep being incorporated into that, and if sleep is the issue, then we can get to that end goal quicker.
Absolutely.
And we can, work on the coping skills. Like, how do I cope with my dysregulation? How do I cope with my impulsiveness? Like when I want to just do something that I shouldn't be doing, we can do all that together. But if sleep is an issue, we'll never get there.
100%.
And they will, they're going to end up just continuing to fight this battle, which we all know that untreated ADHD behavioral disorders lead to so many other things later in life. And we can do all the work we want, which is going to be helpful. But if there's something else in the way, we're not going to get there.
Absolutely. Yeah. That's just so critical. And I think, as we've opened the airway dentists and are pushing this topic, our biggest battle is education. Our biggest battle is, for us, I live, eat, and breathe it. I'm talking about it all the time. I think, you know what a tooth pillow is, right? You can have a tooth pillow. Like they're like, what are you talking about? A pillow for your teeth? Like they don't have any idea. So we've found that to be the biggest, there's a big attractor to the name airway dentist because they're like, oh, that's different. What do you do? And some people do associate that with sleep apnea. A quick visit to our website. But ultimately, they don't have any idea why a dentist would be asking about their sleep. And I think we're the best ones to ask about their sleep. If you're trained in this and you can identify that tooth grinding, snoring, mouth breathing, crooked baby teeth, as the teeth are all coming in, the little things like that they can just immediately identify, okay, that means you're probably not sleeping well, regardless how we might think it is at home. And those are the really easy things I think anybody can implement within their practices, all around medicine.
So let's say that you got the opportunity, like, to go in front of an entire school district full of special education, team leads, teachers, and counselors, and let's go principals and assistant principals. Sure. Let's say you got that opportunity. What would you present to them?
I would present a lot of what you guys listen to in Friendswood. I want to show the tree that we have built with the root cause being underdeveloped arches and airway, but with all the symptoms branching up from it. I'd have, a little under 1,000 cases that I can pick from to show before and afters and what we've seen with the sleep studies and the data. But I think the biggest thing is just what can we change immediately in the way we think about the issue. So like for dentists, for example, I say you go check your patient in a hygiene exam when they're getting their teeth cleaned and you see tooth wear, like they've been grinding their teeth, immediate sleep study. Like it's changing the idea that certain things are normal just because they're common, right?
Yeah.
And so I think it would take the opportunity to present a little bit of literature, explain to them what we're seeing at this level and what we've corrected in kids over the years, and empower them with the knowledge of how they can help their patients, their students, to do better.
We do this, or I say we, the royal we. Right. Callie and her team of awesome dentists do this all the time. I mean, that's all she does in her private practice. We have another associate here, and that's almost virtually all she does. We have 2 other dentists in other locations, and that's all they do. And we still only treat 2 kids a day. Like,
and the people that we talk to that have never heard it before, like they're just completely astonished that there's a link. So I would want to bring together the link. I want to connect what the teachers are dealing with and what the families are dealing with at home to how we can all work together to help better the child. Because that's all it's about for me. I don't care about the narrative. I don't care about the other specialists in dentistry that are going to get mad about it. I could care less. And I used to tiptoe around that a lot. And now I just don't, because I want the best for my kid, and I haven't met a parent yet that doesn't want the best for theirs. And if we can add a tool to the list of the things that these kids are burdened with, from social media to bullying, the kid, like just everything. And if we can make a small change that totally catapults their learning abilities and trajectories, like why are we not trying to do that? And that's where I'm like, I'm gonna end up on the street corner in one of those like blowing suits that's just like, have you had your kids airway checked?
You gotta have a sign and like spitting it.
Oh my gosh, we
need a mascot.
That would be hilarious.
I think that's a great
giant
idea.
tooth pillow mascot. Yeah, just put me in the big.
Yeah, that would work. That would be fine.
Yeah.
Well, I was thinking about your dinner that night, and you had an entire room full of professionals that work with kids. Like you had nurse practitioners, you had chiropractors, you had speech path, you had lactation consultants, you had therapists, and these are all people that have so much education in kids if they're working with them. They were all like, I was looking around the room and everybody's like, what? Like just astonished.
And it just warms my heart. I'm like, yes, we need to know.
But there, to me, what I saw in that was the gap in education for professionals.
Absolutely.
Because why haven't we even gone down this route before?
Absolutely.
Why did I have to learn to kind of think about sleep studies and sleep
On
disorders
your own.
on my own?
Right.
I couldn't even tell you why I thought of that. Aside from just the kid not
Divine intervention.
I know, I was like, why did this happen? But you know, aside from the kid just falling asleep during the day.
Right.
And having behaviors, just the two of them together made me go, well, could be something.
Right.
And then I went and looked it up and I was like, wow, this is something.
Yeah. No, there is a huge gap. And I think that's going to be the thing that we need to work so hard to close. Even just in League City, Dickinson, Friendswood, like,
Let's do it. Just,
like,
we'll stay here.
This is, maybe this one will go viral and then it'll be a whole bunch of others, but yeah.
I think that is, you think that's tough. The patient gap is huge because, and then, of course, anecdotal is all we have, right? This is too early to know if like how intervention really does improve a population. We don't have like a Dunton study to go reference with intervention. And so that's what we're doing every day. That's what Callie and her team of dentists are doing every single day is intervention. And I was reading this anthropology book. I can't remember who wrote that book.
Robert Corcini.
Yeah. And in the opening parts of that book, he references, I can't remember what year it was, but the U.S. Department of Health and Human Services says that orthodontics will be the single largest expense when raising a child.
I mean, I believe it.
Yeah.
And since it got really popular in the 40s, 50s, 60s, it is a huge booming business. And so I've learned just, since my adult brains came in recently, I've learned that money.
I'm going to start calling it that.
Oh my gosh. Yeah. No, I was like 30 before I had adult brains, but,
everyone's different.
Yeah.
She's feeling sorry for you. I don't.
That's validation from my new therapist. Okay.
She only treats kids. You're too old. I'm just kidding.
I see adults too,
Okay,
but I think you got it under control.
Yeah, I think he's okay.
So I can't help but think that there's the gap between the non-dental professionals. There's the gap between the patients, but then there's the gap that I think may be insurmountable and not worth, and that's the gap between the specialists in orthodontics and this, because it is the single largest expense of raising a child, and so it's predictable, right? They've been able to find a way to use metal braces and make it very, very profitable for their own business. So the way that we do it is not the most profitable way to do ortho, but it is the best way. It is, in my opinion, it is effective. So, but that is going to be a hill to overcome because every time we try to educate a non-dental professional, even dental professionals like general practitioners, and the patient, there's never going to be a quiet voice from their corner. And I put their in things because I think most our orthodontists are cosmetic orthodontists. What we do is functional orthodontics here, and so we're trying to improve not just the aesthetic outcome.
Which that comment alone is he's gonna have daggers on social media when this goes out because
that's right. Because I don't have feelings,
which he doesn't care.
You don't need bellies.
He does have feelings.
Well, I'm not supposed to say that to my therapist. But I cope well.
You have some good skills.
But it's for us really. I think even in him saying that, it's to highlight our passion for it getting done right. Like when teeth get pulled for braces, there's no excuse. I posted a big article about that this weekend and it got a lot of comments on
I actually
Facebook.
mentioned it to my mom today. I said how y'all talk about teeth don't need to be pulled. Like it can be worked around.
Yeah. But it's not, it's not taught that way in the ortho residencies. I know that because a lot of my really close airway colleagues are orthodontists and they'll be the first to jump back with me. I mean, I got a lot of initials behind my name, but they'll still hop in and say, oh, well, you're not an orthodontist.
You got some new
ones
today.
Yeah, I did.
You did.
I found out I passed my diplomate test this morning, like 5 minutes before you walk in.
Congratulations.
Thank you.
It was a team effort.
Yeah.
Okay.
The whole family was in.
You watch the kids, yeah.
So, but regardless, until we start recognizing that some of the things that we are doing for the sake of straight teeth might not be healthy for them as when they're 50, like to me, that's a personal issue that some doctors are going to have a hard time with, because they're going to suddenly have to look in the mirror and say, did I do something wrong? I pulled teeth. I would get the letter in the mail as an early dentist. Please pull these bicuspids because they're going into braces. And okay, I pulled the teeth like a robot, right? And I had to turn around and recognize I should never have done that. But I didn't know what I didn't know. So I think if we're empowered with the information, at that point, it's between you and God if you're going to keep doing it a certain way. And I just know that we have to make comments like that. I'm covering for you because of what you just said. In order to make people talk about it. And I think if we can go straight to the patient and empower them with the right questions to ask, I think that's where certain things start changing, because they're going to start demanding certain treatments.
Yeah.
So just to pivot off of airway for a little bit, because I think it's really interesting, like that you said you see 4-year-olds.
Yes, there are not a lot of therapists that see kids that young, but I do.
Tell me, I got to know way more about that, because
we have a 4-year-old.
I mean, like, it's 2023 and no one has not talked about mental health since everyone got sent home from work. Right. And I just wonder how, tell me more about your practice, your pediatric practice, and like the kids, what are some big wins that you've had? Like, I just want to hear more about it. Cause I honestly, like, when you said that, I just looked at the sky. I was like, that's probably good, right? Because if a parent has mental health issues and their kid is struggling, now you have a poorly qualified helper trying to help a suffering child. And I mean, I'm barely a halfway decent mom when she's not around, and I'm a fun dad.
You're hilarious.
But if I have no idea what I would do if I thought that I had a kid who's suffering from something like that. Yeah. So I'd love to hear more. Yeah,
so when I went into private practice, I was like, I'm going to work with adults, because I've worked with kids my whole career as an educator, and I want to work with adults. Adults are surprisingly easier.
I bet.
Kids are like twice the work.
Yeah, for sure.
Because you have a whole, we got to even know what a feeling is before we start learning how to regulate.
Right.
So I got my very first young patient, and I was like, and it was one of those things that they were like, we can't find anybody. And pretty much where you can get treatment for kids that are that young, you're going to see like at a clinic. There's nothing wrong with that, but like a clinical setting, or like ABA therapy, which we did have some ABA therapists there that day. And a lot of people don't want to go that route. They want to just start with a mental health professional in a different kind of setting. And so then I thought, okay, well, is this my thing? And I enjoy working with 4-year-olds. I know, since all of my education, like when I was a teacher and school counselor, was in elementary. And yes, I worked with the 5th graders and stuff like that, and their problems are totally different than
I'm sure.
the littles. But I know those kids. Like, I know the little kids and what they're struggling with. And so these parents come in because they're like, they're having outbursts at daycare, and I'm so worried that, we're going to be asked to leave. And daycares can do that because it's private pay. And so what I start with these kids is identifying their emotions. And I tell the parents that every time, like, we're going to start with figuring out what our emotions are and body signals. So what does your body tell you when you're sad? What does your body tell you when you're angry? And helping them identify those, because when they can identify that, when I'm mad, I grit my teeth. Okay, well, that's signaling my brain that I'm upset and I need to use a coping skill. So we start with identifying emotions, body signals, and then we move into the coping skills. And what I tell parents of my kids, I say, the important thing about coping skills, and this is for kids and adults, is you have to practice them when you don't need them.
Yeah.
So, stressed brains can't learn. So if you're trying to throw in a new coping skill when you're having like a full-on panic attack, even as an adult, it's not going to work, because you have no clue what you're doing. But practicing coping skills that you learn before you need them, and that way you're ready to go. My favorite right now, which this will change, I'm loving the 13, the 12, 13, 14, because they're vicious. They are sarcastic. They have these giant attitudes, and I love it, because once I get them to where they're listening to me and working with me, I've
kind of
gained, I've gained their trust, and that feels really good.
Absolutely.
So when you talked about a win, it's those teen kids that once they start opening up to me and knowing that I'm not there to judge them or discipline them, I always tell them I'm not a disciplinarian.
Right.
And what you say in here stays in here.
Absolutely.
Unless you tell me that you want to hurt yourself or someone wants to hurt you.
Yeah.
And that to me has been really, really fun.
Oh.
But the 4-year-olds are fun too.
I'm sure you hear so many funny things.
Well, in that 50 minutes, because, when you think of therapy, you think it's an hour, but it's 50 minutes because then you spend the next 10 minutes documenting.
Yeah.
That 50 minutes flies by.
Absolutely. I'm sure.
It's so fast. And plus I'm not a registered play therapist, but I do incorporate play therapy because that's really the only way you can truly work with kids at that age. You have to be playing.
Yeah.
Because they don't know. They have no clue what you're working on.
Absolutely.
They just know that they're having a good time.
Right. Oh, that's so sweet. I love that.
Do you have any nonverbal patients that you're
I
working with?
don't. I don't. But I would totally be open to work with nonverbal patients. I've in a school setting, I've worked with children that were selective mute or just nonverbal in general. But as a school counselor, you don't get to stay with those kids long because they end up going the special education route.
Yeah.
And so they kind of get taken away from you pretty quickly.
Mm-hmm. Wow.
Yeah.
Well, I am really happy we did this.
I know, me too.
too.
This was so eye opening.
really
and I
easy.
see so many areas where we can work together and better the health of our county.
Yes.
I'm starting with the county.
Let's start with Galveston County.
Yes, that's a pretty large county.
It's
but
really
we got
big,
it.
but we can do it. It's fine.
I know.
Like
I know.
I said, 2 a day is how many cases we start essentially, and that's busy. So this is not this is all about education and helping the kids. Like if and I was honest, if Merritt called their Houston office and said, "Why are sales down?" That is why I would be alive. Like that would be so cool.
Yeah.
But thank you for coming all the way here from Santa Fe.
Oh yeah, my 20-minute drive
It was a big deal.
Brutal.
I know.
And I guess just to close out, why don't you share a little bit about where people can find out more about you and your practice and how to get in touch?
So my website is amyharlowcounseling.com. Pretty simple. You can go on there and you can request a free consultation if you want. So I do 15-minute virtual consultations for free. I see patients in person and virtually. Awesome. So either or.
Oh, nice.
And then my Instagram is Amy Harlow Counseling. That's the handle. I'm trying to do more on there because, you got to promote.
100%.
I also have a Facebook page that's Amy Harlow Counseling. It's just the page.
Wonderful.
And so that's how you can find me.
We'll make sure to tag that in this video and you can share it with everybody on your end as well. Thank you so much for taking the time to come out.
That we talked about the studies.
I was like, can I have that?
You can.
Oh, yeah,
we have another one. Take both of those.
It's going to take these.
This is the PhD that you're.
I didn't put any ketchup on those.
Dissertation.
My dissertation. Ryan is going to hear this and he's like,
we're going to have to meet Ryan. We're going to have to be like, come on, man. No.
Yeah. He's pretty fun too.
Send her to school. Come on.
Send her to school.
He's very personable, talkative engineer, which I know is not, always.
He comes from a whole
when
family.
you said you got into counseling after you met those engineers, I was like, that makes sense. Okay?
Yeah.
My dad is a biomedical engineer. He's worked at NASA.
Oh, yeah.
My grandfather is a chemical engineer. My uncle is a civil engineer, and the other side of my family are architects. So I grew up, and I told my dad when I finally decided I want to go to dental school. He was like, "Why?"
He's like, no. He's like, but you need. Do they spreadsheets? Are there a lot of spreadsheets?
Oh, there's graph paper.
Graph paper
everywhere.
And to troll. Now we're just rambling. But to troll my uncles and my granddad and my dad for Christmas when I was 18, I wore a shirt that I found at the mall or something. Maybe I was 17, but it had a giant equation on it, and it said something smart. I could probably get Spencer's or something. And it said don't talk to me until you can figure out this. And it's a giant equation. Well, I wore it, and that became the thing they had to solve.
Oh, I bet, and they can't move on.
They ruined. They
ruined Christmas.
They tried to. We were at my grandparents' place in not Brennan, but in Meyerland in Houston, and they had graph paper. They knew this formula. I was like, well, at least
kept them busy.
Yeah,
because you kept them distracted.
If they don't do that, they go build something. They're like, hey, let's build a barn. Yeah. We're here already.
Yeah. Well, she's living that. He's building her.
There's a lot of building that goes on in our family.
I think it's kind of handy.
But then I got a D in calculus when I was a freshman in college, and
you're like, this is not for me.
What's wrong with you? I was like, well, I just don't like it.
Yeah, it's not my. If you don't like math, it is not your thing.
It's been so much fun.
So, well, thank you, Amy, and thank you everyone for listening.
I appreciate it.
yeah, we'll be on with another guest. I don't think we know who our next guest is, but
yeah, we can't.
we're
No
going to find
teasers yet.
someone.
Pull them off the street and have them talk to us. No,
Yeah,
I'm just
we'll get
kidding.
the sign. The sign.
Get the sign out there and then just say,
I'm
hey,
gonna twirl
we're doing a
something.
podcast.
Come on in. Thank you. Have
All
a good
right,
one.
thank you. Bye.
Bye.